Welcome to Dr. Jeffrey Roth's Looking Good and Feeling Great podcast, live from Las Vegas, with his co-host, Daryl Craig Harris.
Hi folks, it's Dr. Jeffrey Roth here, your board-certified plastic surgeon, and welcome to our podcast.
It's I have to check the episode number because now we've actually been doing this now for a couple of years. We're kind of tooling along.
That's right. The FCC hasn't written the letter yet, so we're still rolling here. So
exactly, and we're coming to you live from the office. So if you hear a click or an air conditioning, that's why. But we're live and real.
Yes, this is so one thing is you're going to get an unvarnished opinion. So apologies in advance. So
we were talking about, and we've talked about this before, but it's a great subject, is breast implants, and that the fact is that they actually do need to be replaced. They're not lifetime devices. Can we talk about that subject?
Absolutely that. Now, Las Vegas, where we are, has always been a big breast implant town, chuckle. But we get that number actually from the manufacturers, that it's New York, Los Angeles, Las Vegas, Miami, and Dallas that have the most implants sold. And so as far as care of the implants, I mean, we here, Las Vegas Plastic Surgery, and again, most board-certified plastic surgeons will really go ahead and sit down and talk to the patient before, during, and after the case as to how to take care of things. Some folks like massage. We like massage. Some folks not so much, et cetera, et cetera. But they're medical devices and have to get taken care of. And even in my particular world, what I do, because I'm a little bit nutty about sterility and that sort of thing, is I actually lock the door to my operating room when I'm in there doing my thing and bringing forth the implants and putting them in. And people say, well, why are you doing that? Why are you going, all to that extreme? And I look at it same as a heart valve or a total knee or a defibrillator or something like that, and take it as seriously as that. So I don't like the door opening, closing. I think it messes up the laminar flow that they have in the operating rooms. And also there's been a couple studies out of Europe that show that the more times you open up the door, the more the infection rate goes up. So I actually lock the door when I'm doing implants, and the nurses tolerate me, and they kind of know, the shtick, and so we kind of go from there. So there are a few things, obviously, to prep, before, during, and after. And then we also talk about the after before we do the operation. And what I mean by that is people ask all the time is how long can they stay in? Are they permanent? And as we alluded to earlier, they're not permanent devices. Nothing really that we, man, put into a body really typically stays there forever. Some stuff, but most of the time it's got to be kind of switched out. So implants are no exception to this, and there used to be, kind of a rule at 10 years to go ahead and switch the implants out. And that was true back in the 80s and 90s when the leak rate of the silicone implant was about 50% at 10 years, which is kind of high. So you had a 50-50 chance of your implant being leaky. So that's why that 10-year recommendation was made. Nowadays, things have gotten so much better, and the technology has got so much better that leak rate is down between, depending who you read, about 5%. And so again, that's a ton better. Now, having said that, is the technology, not only the shell is better, but also what's inside is better as well. For example, the old silicone implants had a consistency of maple syrup, right? And so when they leaked, they kind of leaked all over the place. In fact, Desert Springs Hospital here in Las Vegas used to have on their kit, if you had to go to the operating room with a leaky implant, that they actually had a sterile spoon that you would go ahead and use to kind of ladle this stuff out of somebody's breast. So that obviously has gone away. And then nowadays we have the gummy bear or cohesive gel implants, and their consistency is much like a gummy bear. So if, God forbid, there's a little bit of leak or something else like that, it can all come out basically usually in about one piece. Now, the new implants are really sort of neat because allegedly you can poke a hole in it, shake it, and nothing's supposed to really, come out. Kids don't try this at home. But having said that, it's just, a much better implant as far as that goes. But still, people ask, well, how long should they stay in for? And I say, well, the new gummy bear cohesive gel implants, usually if you can get a good 13, 15 years out of them, that's a pretty good run. But again, everybody's different. And again, I've seen implants old school saline implants from back in the day that have been in there for 30 years, look good, feel good, and the pendulum has swung that most people would leave them alone. But having said that, is as far as monitoring the implants and all that, the FDA, when the silicone implants came back on the market because they were the new implant, et cetera, they made a few recommendations. One of the recommendations was an MRI at year 3, and then every other year to kind of monitor how things are going. And the reason why they made this recommendation was because they wanted more data points as to when the actual failure happened, et cetera. And implants, by the way, breast implants are the most studied thing that we put into a body. That's right. There's more studies about this than there are heart valves or defibrillators. So go figure. But it is such an emotionally laden issue, and so that's really why that happened. So the FDA wanted to go ahead and get more data points. Now it's an unfunded mandate, so a lot of people don't spend the $1,000 or whatever to do that, but they do that. Now, some people have also been talking about ultrasound for monitoring, but that, again, hasn't made it to the level of a recommendation. So that's kind of what is going on as far as monitoring goes. So the next thing is, okay, well, when do you think they may have to get switched out? Well, we talk about indications, the why. Indications for surgery. Some indications for surgery are really clear-cut. Gunshot wound to the chest. You're going to the OR. So that one's pretty basic. So some of the indications for, hey, let's go back and switch this out, maybe the age of the implant, like we talked about, if there's a difference in the implant, if there's significant rippling or something was weird or wacky, if the patient's having pain, if the patient's having capsular contracture, capsular scarring, and then if there's an issue with the soft tissue. For example, waterfalling. And what that is you have the implant in, and then with time, the body's soft tissue will kind of waterfall over the implant. And we see this mostly in gals that have had a couple of kids or folks that have hit perimenopause or menopause. And so we see that. Another indication would be ptosis, which is the fancy medical word for droop. And that's when it gets longer and longer from the nipple areolar complex to the sternal notch, kind of where your neck is. We often see the droop with folks that have neck and back pain, so that's pendulousness, right? And so oftentimes, if we do a removal, replace, or a lift, or a reduction, I think a lot of the pain will go away because you have this pendulousness, and it's kind of like having a backpack and the straps are too long, and so you go ahead and you put the backpack straps shorter, and so it fits on the chest better. And we've seen that time and time again that's also helpful. Also, some folks just want to downsize, and we've been seeing a lot of this in Las Vegas, is because people had these back in the 90s, the 2000s, the 2010s, and, they had a couple of kids. They may have gained or lost weight or whatever the case may be, and they're like, okay, yeah, enough already. And so instead of being a D, double D, they start off as a C, now they're double D. They're like, okay, can we remove, replace, can we downsize? And oftentimes that works really nice because you can kind of keep that upper pull fullness that the girls like, but then you can kind of downsize things and make things a little bit more proportional. And this will happen, again, as body changes happen. Also athletic changes. Some folks that weren't athletic, now they're big-time runners or whatever the case may be, and they're like, these just don't fit my life anymore. And so there's lots of indications, and there may be more than one, to go in there and remove the old implant, replace it with a new implant, or sometimes not even do that. Now, typically when you downsize, you typically will need a lift because what will happen is the nipple areolar complexes will also kind of, go downward. So one of the most popular operations we do, believe it or not, is exactly this, is they remove, replace, either stay the same, downsize, and a lift. We actually do more of those than we do primary augmentations nowadays. So, and maybe it's because of the demographic that comes into my office or whatever the case may be, but that has really become a very, very popular operation.
What would be like a typical round of questions when you see a new patient, they're interested, maybe they haven't had implants before, they're interested in getting a breast aug. What would be the most common concerns about implants?
Well, sure. Is basically, well, it's kind of myth busting when people come in. It's just like, oh, do you have to take them out? Every 10 years. Tell me about, breast implant illness. Tell me about ALCL. If they don't work for me, what can be done? And people usually have some very, very good questions about all of these topics. And in our office, we sit and we talk to them and we address every question that they have. And I am absolutely not efficient. I've had lots of consultants come and say, oh, yeah, most guys are, 7 minutes a patient, doc, or maybe 15. We block out 45 to an hour for every new patient. And it drives consultants and it drives my office manager bananas. But this is that patient's shot to go ahead and really get, what I like to think is good information, or at least information from somebody who's board certified, lives in this space, likes going to conferences, likes going and reading about this and trying to disseminate what's all out there and then apply it to the patient. And then oftentimes we get really, really good questions and I got to go look it up, or I got to go talk to a couple of professor friends of mine and try to go ahead and give them the answers. But oftentimes it's really kind of how it's going to affect them. It's going to how it's going to affect their health, how it's going to affect their long-term life, etc. So we get all those sorts of questions, and we like to think that we're equal to the task, or at least we try to go ahead and give them a good understanding. One of the things I say all the time is I would rather you spend 20 minutes with me than 20 hours on the internet, right? So Dr. Google, not necessarily your friend, right? And again, if I don't know something, I'll say, do you know what? I don't know, but I think I know a couple of guys and gals who might, and I'm going to go ahead and call them and do some detective work, and I will tell you.
Yeah, and plastic surgery, I guess in life in general, we're always learning. And you think it's really important for surgeons to be continually learning and updating their techniques and their knowledge.
Oh, absolutely. And we've talked about this before. And I had an old professor of mine, the late Gil Gradinger, who was fabulous, man. And he told me, he said, Jeffrey, he says, if you ever get bored in plastic surgery, you're not reading enough. Because especially the microsurgery guys and gals, I mean, they're taking tissue from one area of the body and transferring it on little itty bitty tiny vessels to another part of the body. It's amazing. And the technology that we have is so much better. For example, breast reconstruction surgery is the lady comes in, you take off the breast, you clear the cancer, and now it's time to go ahead and reconstruct things, okay? And back in the day, we used to go ahead and put the implants behind the pectoralis major muscle, and then we would also go ahead and move the other muscles on top of it. So you would have to have total muscle coverage, otherwise it may the implant may go through the skin, because again, there's no breast tissue there anymore, right? So we did that for forever. And then I was at an ASPS meeting, American Society for Plastic Surgery meeting, and there was a one of those kind of dinner, have dinner and learn about the new thing. So I went, and they were talking about putting the implant on top of the pectoralis major muscle, and then putting the stuff called acellular dermal matrix ADM on top of that, and reconstructing that way. I almost fell out of my chair because that was absolutely sacrilegious from everything else that was taught. And at the end of the dinner, I didn't even stick around for dessert. I ran up to the guy and I'm like, "Are you for real? Are you really doing this?" He says, "Yeah, it's amazing. We have a series of X and blah, blah, blah." And there's another guy on the East Coast that's doing this, another guy on the West Coast is doing this. And so that, I don't know if it's called, I don't know if we would call it the standard anymore, but that really, really has helped a ton of women get through this with much less morbidity, and you don't have to raise up the pect and everything else. So, and that's just one aspect of it. So there's so many things going on now. So and I enjoy learning from new folks. And what I love about going to conferences is you go and you see, your old friends and this and that, and you learn about the sessions and all, and then you go to lunch. And my favorite part is lunch, and not because of the rubber chicken box lunch sandwich they give you, but it's usually a round table. And there's usually me, a guy from Vegas, and then there's somebody from New York, some from Brazil, someone from Mexico City, and one guy will say, "Hey, what'd you think of that last lecture?" And one guy will say, "Oh, I think it's great." And the other guy says, "Oh, I think it stinks, and I'll tell you why." And they go back and forth, and that's really cool. Or somebody will say, "Oh no, I was his fellow. He doesn't do that the way that anymore. And this is what we really do." And so if you can pick up like 2 pearls from every meeting, that's a good meeting. And nowadays, because a lot of the meetings are remote now and all that kind of stuff, there's a little bit less of that. Now, having said that, there's been a few other conferences that really have come out to try to limit a lot of, the glitter and glamour. Dr. Lauren Rosenfeld, who is a professor and now a friend of mine, has this indie conference, which basically he gets all these luminaries in the field, and all of the BS goes right out of the window, because they actually have other guys cross-examine them, et cetera, and it's really interesting to see these guys and gals that are usually up on the podium, et cetera, really getting grilled by a peer, and the truth really comes out. And so that's a lot of fun to go ahead and see. And again, that you can pick up a few pearls that you can like immediately help out your patient with. So to your point is always you have to be learning. And I tell my daughter this too, is you can't stop learning. You always have to pick up books, and reading's important. You try to go ahead and talk to your friends. And here in Las Vegas, we have the Las Vegas Plastic Surgery Society, and we usually have a speaker that comes in. Oftentimes, we'll go ahead and present our cases that may be difficult and that kind of thing. And then you have a bunch of other board-certified plastic surgeons in the room say, "Oh, yeah, I would do this and this. And no, don't do it that way. I tried that, but this is better." And that's better for everybody. So if everybody can check their ego at the door and concentrate on what's important, which is the patient, then really good learning and really good patient care can happen.
Yeah, I think and learning is important, and also obviously techniques are always changing and updating, so it's great to stay abreast of that. And one thing I've been seeing a lot of lately is fat transfer for breast augmentation. Can you touch on that topic?
Yeah, so it's a little bit controversial as far as that goes. So fat has been moved around the body for a long, long time. In fact, it's arguable that the very first breast augmentation was transfer of a lipoma to the breast to try to go ahead and kick that out. But that was years and years ago. Okay, so fat. So fat as a filler material, and this is, again, very controversial, and we have conferences all about fat and fat transfer, and everybody argues, and nobody gets their minds changed. That's kind of how that rolls. Fat, I think, is a good substance for certain indications. For example, if you have like a golf ball size divot in your butt from a Kenalog injection, because sometimes you'll go ahead and they'll go ahead and put Kenalog in your butt if you have a bad bronchitis or something along those lines. And it's a very good treatment. But in some cases, very, very rarely, you'll get a little bit of fat necrosis, and you wind up with like a dent or divot. So they send them to me, and I'm like, oh, okay. So we go ahead and we find some fat, and we usually can find some fat, even the skinny girls, but with some exceptions, of course. And then we go ahead and put it in that dent. Now, the thing with fat's kind of interesting because, again, do you spin it in a centrifuge? Do you let it settle, et cetera, et cetera? And again, these are all technical points that we argue about. But the whole idea is you go ahead and you put fat into an area. Now, you have to overfill it. You got to overdo it a little bit because about 40% of the fat is going to go away, right? So, and then sometimes you have to go back, and people are like, well, why am I going back? And so, well, that's kind of the way fat works. Okay. So fat can be a little bit unpredictable. Sometimes it can be a little lumpy bumpy. Sometimes you can get cysts in there. Sometimes you get calcifications. And the problem with fat calcifications and when you put it in the breast is traditionally certain types of calcifications read on mammogram are cancer until proven otherwise. So mostly in the past, the radiologists have gotten much better, et cetera, but in the past, some folks have gotten biopsies, et cetera, because of these calcifications. So For me, I never jumped on the fat bandwagon. Now, having said that, I know a lot of folks that do a lot of this and they get great results, especially those folks that work in reconstruction where you've taken off the breast already. You really don't have anything else there and you do the reconstruction, but you maybe have some ripples or some divots or something along those lines. Then I think absolutely go ahead and put some fat up in there, and these guys and gals really know how to do that. And I think that absolutely makes sense. So for me, that's kind of the fat thing. The folks that you get online, and again, most of these folks aren't board certified plastic surgeons, and they'll say, "Oh yeah, forget about implants. Come to me, and we'll go ahead and get you bigger breasts." In reality, you can probably go up one size. In reality, from like an A to a B. Now, back in the day, they used to use this Brava system, which was like two big suction cups. You kind of look like a fembot up top of it. And that whole idea is to go ahead and stretch out the soft tissue and make space for the fat, and then put the fat in there. And there's a few people that I respect that did that, and they got some good results too. So there's obviously more than one way to skin a cat. But if you really think that you're going to go from an A to a D with fat, in primary breast augmentation, I would warn people away from that. And for me, now that we have these implants which are really, really good and they come out of the box and you really, for the most part, know what you're going to get with them, that's where I tend to be. So again, that's just my opinion. It's controversial in the literature and also on stage at these panels that you go to, but that's kind of my take on that.
Yeah, and it seems like sometimes too, some it's almost like fashion. There's the trends that happen, and everybody jumps on this bandwagon, that bandwagon. But ultimately, for the patient, it's long-term safety, long-term positive effect while they're spending the money to get the result. Right?
Absolutely, and then we've seen things come and go. Back in the day, even talk about Brazil. Brazil used to be very small bust and then kind of a big butt. And then Pam Anderson showed up in the 90s and Playboy and all that. And then all of a sudden, the request for breast augmentation in Brazil went up exponentially. And so that was kind of interesting. Some beauty doesn't change. And there's been some folks that have tried to mathematically determine ratios, et cetera, especially facial symmetry and facial attributes and that sort of thing. And there is something to be said for that. But there's some standards that are always kind of going to be there. But having said that, yes, there can be some beauty fashion changes. For example, BBLs, they were all the rage for a little bit, and now some of these folks are coming back in and going, is there a way that I can get this reversed, et cetera, et cetera. So it depends. And we talked about that earlier. It depends on what's going on in your life as well. I mean, we had folks that were, cocktail waitresses. They were size 2, running around and stuff like that. And now they're status post 3 kids. They've hit perimenopause and like, okay, these grew into double Ds enough already. You know what I mean? Can you can you go ahead and switch them out and lift them up while you're at it and make them smaller and
right,
so.
because what you wanted when you were in your early 20s may not be what you want when you're in your early 50s.
And we hear that all the time, which is, oh, these were great, I loved them, but I'm at a different place in my life, and that's okay. So
yeah, and that's just how things are. But I think ultimately too, it's really just about the patient and their safety and ultimately getting the result that they want, because it's a significant investment.
Oh, 100%. So of time and energy and resources and effort and everything else too. And we give folks the options. For example, folks that come in, and especially after having a couple of kids, and they lose the upper pole fullness, and they need a lift. So we know they need a lift. And the next question is, and this is very common because women will do this in the mirror, and they'll go ahead and move everything up towards their clavicles and go, oh, that looks great. And I'm like, that's terrific, but that's not reality. So, and then we go ahead and just lift the nipple areola complex up without touching the upper pole. And I'm like, okay, that's what it's really going to look like. And I said, if that's cool with you, if you like that, that's a lift. I said, now, if you want that upper pole fullness, and they usually don't want the upper pole fullness that you put a drink on top of it, okay?
Right, because it doesn't look natural.
Okay,
right?
but right, and some people like that aesthetic too, and it's Vegas, and okay, we get that. Yeah. But having said that, is I said, look, if you want that upper pole fullness, then yeah, that comes from an implant. And it may be a small implant. Folks may say, look, I'm a C, I really don't want to go, big. I like my proportion. So we go on purpose with a smaller implant just to kick out that upper pole fullness and give them what they want.
Yeah, and ultimately it's about the patient, making them happy, right?
Well, yes. So within reason. I mean, they come to me, I like to think they come to me not just to cut and sew, because at this level, everybody should be able to cut and sew, but also for experience and training and judgment. And to say, well, we could do this, but I would recommend X, Y, and Z. And sometimes people will be right between two choices, and I'll go ahead and give them 2, 3, however many choices, and I'll just go, all right, what's the aesthetic that you're looking for, and then we can go back and forth and kind of figure out what works for them. So
right, Dr. Roth, tell people how they can reach you, contact you, and you are very open to questions as well.
100%. We love questions. In fact, a lot of the things that we do are from questions that we get. In fact, today was all about questions that we got here in the office. So we're all over the place. Our flagship is, of course, the website, which is www.jjrothmd.com. That's jjrothmd.com. And so that's kind of the flagship. And then also social media. We have Instagram, Facebook, YouTube, and Twitter, now X. And so we're out there on all those platforms. And of course, you're listening to us right now on our podcast. And we still answer the phone. So by all means, go ahead and give us a call. And if you want to hear something or address something, please reach out to us and we'll get it on.
Yes, and all that information is available on the podcast description. So please take a look there. And you're welcome to contact the show, and we'd love to hear from you. And if you have questions that you would like us to answer on the podcast, please let us know that as well. And don't forget to like and subscribe. Thank you so much, Dr. Roth.
Thank you so much. Always fun to do this. Everybody have a fantastic day.
Absolutely.
Thank you so much for joining us. For further information, please visit the podcast website link for Dr. Jeffrey Roth. See you next time.